Hello and welcome back to Breaking the Consensus here at Protect Life. Thank you for joining us. Before we get into the discussion today, I'd just like to remind you, if you like to click on the like button and to subscribe, then you'll be advised if any new material comes up that we have. Also, even coming out of the pandemic, we have lots of work that we have to do and we need your help to do it. So the donate button is there. Anything you can give small or big will be much appreciated and will be used to the best of our ability to support those life issues that we all share. Today, I am delighted to be joined by Dr. Dermot Kearney, who's joining us from, well, I don't know where he's joining us from, maybe he'll tell us that. But anyway, thank you for joining us, Dr. Kearney. How are you?
Thank you, Michael. It's lovely to be here. Thank you.
So you're in England, but, well, my suspicion is raised by both the name Dermot Kearney and the accent that you are not perhaps an Englishman. Could you just give us a bit of a background of your bio, and you're a medical doctor, and how you got into and where you are today?
Sure, thanks, Michael. As you correctly identified, I'm from Navan, County Meath, qualified in medicine in 1989 from UCD. I actually went into medicine with the intention of going to help in the developing world. I came across when I read a book in school by an English doctor called Sheila Cassidy. The book was called Audacity to Believe, and inspired me that there was a great need for doctors to help the poor, basically. So I even started to learn Spanish at the same time. But it struck me, well, just after I qualified, I remember talking to one of the patients in the Batter Hospital about this and telling her my intention to, once I'd done a couple of years of training, to go to the South America or Latin America, El Salvador, Honduras, were the big areas in those days where there seemed to be a great need. And she said to me something that struck me very much. She said, don't go to those foreign places. There's a need for great young doctors here. And it made me think, maybe she's right. So I never managed to get to Latin America. And also some of my colleagues during their student years, they went to some of the developing countries as part of their student training. And they felt that they had very little to offer because the local people could do it. All they needed was the resources. So to actually send in personnel may not be the answer. So maybe there's a great need for sending antibiotics and modern medicines and modern techniques and hygiene and training, but the local people, should be well able to do that themselves. So I never made it to the developing world. I ended up working mostly in Ireland, but I spent 2 years doing some additional training because I'm a cardiologist as my main speciality, and also specializing in acute medicine, acute general medicine. And I did a 2 years extra training in Holland, in the Netherlands, before I took up a post in the north of England as a cardiologist and a general physician. And I've been there for the last 18 years.
You are, as it were, in the news at the moment because of treatments that you've been giving regarding interrupting the process that goes on when a woman takes the abortion pill. So before we get into that, could you explain just the science or the technology, as it were, behind the abortion pill? Also, shall we say, just like at what stage in pregnancy, what are the parameters that are used, and what situation would this normally be prescribed?
Yeah, well, as a lot of your listeners will probably know at this stage, that the majority of abortions in this part of the world, and in the UK, it's about 85% at this stage, are carried out by medical means rather than surgical means. It's a little bit less in other countries like the US, but it's about 80 to 85% in the UK, and has been increasing over the last 5, 6, 7 years, year by year. And the medical abortions are carried out by, it's a 2-stage process where the woman takes, once she's discovered she's pregnant and doesn't want to continue the pregnancy, she takes a first pill called mifepristone. Mifepristone is a progesterone receptor antagonist. And that's very important because progesterone is a natural female hormone that's produced during pregnancy. Well, obviously it's produced outside of pregnancy, but extra progesterone is necessary to maintain a pregnancy. It helps with the development of the lining of the womb so that the fertilized egg can be implanted and can stay alive throughout the development. So progesterone is essential to maintaining pregnancy. So the first abortion pill interrupts the effect of natural progesterone by binding to the receptors that progesterone would normally bind to. So it prevents progesterone from having its effect. It causes it interferes with the process of what's called decidualization, which is the developing of the lining of the womb and the attached placenta, or the precursor of the placenta. It basically starves the developing embryo or fetus, depending on what stage of pregnancy, starves it of essential nutrients and oxygen. And then 1 or 2 days later, so 24 to 48 hours later, a second pill is taken to complete the abortion, called misoprostol. Misoprostol is a prostaglandin analog, which causes contraction of the womb and expulsion of the developing child and the other products of conception as well. It's important to point out, however, that a number of pregnancies will be, completely interrupted, even just with the first pill alone. And in some developing countries, especially where mifepristone is quite expensive, sometimes the second pill, misoprostol, is used as a single agent. Other agents are used, but in general, in this part of the world, mifepristone followed by misoprostol 1 or 2 days later is how the vast majority of medical abortions are carried out.
At what stage in pregnancy does normally this take place?
Oh yeah, so most people, most women won't realize that they're pregnant until they've missed the first period. So by law in the UK, medical abortion can take place up to 24 weeks. It's not recommended even by the abortion providers. They generally advise women, if they want to have an abortion, or termination as they would phrase it, that it should be done within the first 10 weeks. And the majority do take about 80% or so, maybe even more than that, would take place within the first 10 weeks. So usually between 6 and 10 weeks of gestation. However, there are plenty of reports of women, and I've come across many myself, who seek abortion at a later stage. And now that with the COVID pandemic, it's much easier for women to obtain the abortion pills. They can do so now without it having to attend a clinic. They can simply make a phone call to the abortion providers, such as BPAS or Mary Stopes or UPAS, and they explain their situation. They're asked a few simple questions, and they will receive the abortion pills, both mifepristone and misoprostol, and a little kit for pregnancy tests. So they'll receive that by post within a matter of days, and then they can decide to have their abortion at home, which the majority are taking place in that way at the moment. And there's no way of knowing that while the person on the other end of the telephone will ask them, what stage are you at, or when did you have your last period, or have you had a scan? There's no way that the person on the other end of the telephone actually knows if truth has been told. In fact, they don't even know if the person to speak to is actually the pregnant woman. It could be someone else obtaining the pills for somebody else. And there have been reports of abuse of the system. In fact, one report last week, which apparently has been under investigation by the police, is of an abortion taking place well outside the legal limit of 28 weeks by medical means. But certainly I've come across many which are well into the second trimester, which is beyond 12 weeks.
If you have a medical abortion taking place, say after 16 weeks, 18 weeks, does that elevate, or does it create a risk, or is there effectively no risk to the woman in this case?
Oh, there's always a risk. Even earlier, that there are risks. In fact, we know from Freedom of Information Act that, and when this has been looked into, mainly by some of the pro-life groups who have access to freedom of information, that there are on average 495 emergency calls to ER departments or A&E departments in the UK as a direct result of complications related to medical abortions. And the majority of them would be at-home abortions. Some of them would have been taking place in clinics and then they develop problems sometime later. And that's probably an underestimation, because a lot of the women understandably don't want anybody to know, especially doctors that they might be attending or nurses, that they've actually had an abortion. Mm-hmm. So the ones that we know about, there's an average of 495 cases who attend for emergency care each month, every month. And that has been the case since the COVID lockdown, so almost 2 years at this stage. The main complication is hemorrhage, because women bleed. Mm-hmm. And when you take mifepristone, as I mentioned, it interferes with the normal development of the lining of the womb. The abortion providers, to some extent, are a little bit truthful. They do tell the women when they're receiving the medication, the abortion-inducing medication, that, it's just the same as having a heavy period. And that's not entirely untrue. Although depending on the stage of pregnancy, heavy, some heavy is much more heavy than others. So if you have an abortion, a medical abortion in about 5, 6, 7 weeks, you'll get lot less bleeding than if you have it at 10, 12, 14 weeks. So the later the stage of the abortion, the more heavy the bleeding, and it can be life-threatening. And women have died. Not many, but women do die. We know of one woman, unfortunately, that has died in the UK in the last 12 months as a result of a medical abortion. We know of at least 24 women in the US that have died directly from complications of medical abortion, legal medical abortions. And I'm sure it's much more in other places around the world. So these drugs are not benign. Women bleed. Most women who take the first abortion pill will bleed. Some don't, but the majority will. Sometimes it'll be a relatively light bleed, won't require any particular emergency treatment, but some, as I mentioned, will have to attend hospital. There's also, as well as bleeding, I suppose the second commonest complication would be infection, mainly because of some tissue not being completely expelled from the womb, even if they've taken the second abortion pill, the misoprostol. So some women will need to get urgent or emergency even antibiotic therapy for retained products of conception. And then quite a large number actually have an incomplete abortion, and roughly of those, about 50% will require additional surgical procedure to remove the tissues to prevent infection and prevent ongoing bleeding as well. It's also a very painful process, particularly later in pregnancy. So women do have to endure a lot of pain. They are given some painkillers, I think, with the pack, but sometimes it may not be sufficient to control the amount of pain. And in addition, then there's the psychological trauma of seeing what they can easily identify as a well-formed fetus being expelled that they're told to flush down the toilet. And, there have been many heartbreaking stories, true stories from women who have been shocked when they see that it's not just a blob of tissue or a large blood clot.
The famous clot.
Yeah. So there are a lot of potential problems for women with medically induced abortion. And the other thing is that they're on their own, so they're not getting oversight from medical practitioners or nurses. They can contact the departments who provided the medications if they have difficulties, but it's not.
Okay. You enter into this story because sometimes we know that women will take the pill and then regret it, and they go on Google searches, or they may have been told that there is possibly a way to stop the abortion going ahead. So can you just explain, you were responding to a need. I mean, this isn't it's not, I think this is something I want to really bring out, is it's not that you were going out looking for women, because there's a phrase I came across in one of the reports where they talked about you imposing your anti-abortion beliefs, which I think it's very important that people understand. It's not that you were wandering around the streets of towns of the north of England with a lamp looking for women to make them feel bad or guilty about this abortion. Rather, there are women, and significant numbers of women, who experience regret, who maybe, we'll get down to that later, would have made other choices had other choices been given to them, but they experience regret and they go looking for help. So, and you're aware of this, and you and some perhaps other doctors wanted to meet this need. How did that work?
Yeah. Well, first of all, before I go into that, I will just mention that I'm not allowed, and we'll explain why in a few moments, I'm not allowed to prescribe, administer, or recommend progesterone for abortion pill reversal, and that'll become clear in a few moments. So I want to say that at the outset. This came about, I'm a member of the Catholic Medical Association, and back in 2014, so quite many years ago, we first became aware, myself and other council members of the Catholic Medical Association became aware of this issue. Up until that, we knew there was medical abortions. We didn't know that there was any possibility that there would be help for women who might change their mind. And as you correctly state, many women do change their mind for various reasons. Usually because they've decided to go ahead with abortion in the first place under some sort of coercion or pressure from other people, and then they regret it, having taken the first pill. So we became first aware when we got a plea from Jack Scarisbrick of Life, the organization Life, who heard of cases in the US where this was being promoted, and he asked, could the Catholic Medical Association do something about it? At the time, we were very skeptical. We looked at all the negative aspects of it. You know, could it be effective? Was it safe? Would there be legal implications? Would it have any impact on the child if the child did manage to survive? So we looked at all of these issues. I spent personally 5 years researching the issue. Back in 2014, there wasn't a lot of information, but by 2018, 2019, there was more and more information becoming available, and more reports of success and safety coming from the US. And in 2018, Claire McCulloch from another pro-life organization, Good Counsel, approached the Catholic Medical Association once again and pleaded with us that they were getting more and more women coming to them that they couldn't help, that they had to turn away. There's nothing we can do. There aren't doctors in this country, in the UK, who are prepared to help you in any way. They did occasionally send people to private practitioners in Harley Street who charged a fortune for the services, I believe. And Claire has the receipts to prove it. But that wasn't something that could be done on a widespread or long-term basis. So at that stage, I went to the US. I met many of the people involved who were providing this abortion pill reversal service using progesterone treatment. I mentioned that mifepristone blocks the action of natural progesterone, and they found initially by accident, and then by research and studies, that actually, if progesterone can be given promptly, then maybe it has the possibility that it can prevent at least the ongoing effect of mifepristone. Mifepristone doesn't have an immediate effect in many cases. Sometimes it does. Sometimes it, there'll be heavy bleeding very quickly after taking the first abortion pill, and even before the second pill is taken, the abortion has been complete. But sometimes it doesn't. Sometimes it's a little bit slower to act. So it's probably an incremental way that it binds to these progesterone receptors. So it's found in some cases that giving high-dose progesterone at an early stage might, in some cases, be able to preserve the pregnancy, save the baby. Now, the only way that we could offer this service was myself and another doctor in the UK. We again looked into how could we possibly give the service to women who were obviously looking for the service, looking for help. And we found that, well, the same way that they went on the internet to find out was there anything available, usually on Google, and we found a group in the US called Heartbeat International that holds a register of doctors who are prepared to provide the service for women throughout the world, mostly in the US, of course. In fact, they've got 600 or 700 doctors in the US who are registered with the organization. So that means that in different geographical areas, if a woman, changes her mind after having taken the first pill, goes on to Google, finds abortion reversal, she can dial this number or contact them by email, and they will then try to find a doctor in a local area that might be able to provide assistance to the woman. And that's what we did. Myself and the other doctor, we registered. So at least that if a woman from the UK contacted the helpline, that they could be put in contact with either of us at any time, day or night. The majority of them were quite late in the evening, which made it quite difficult because we then had to try and find a pharmacy which was open and that had the medication in stock that would be convenient for the woman to attend. So no, we weren't going out looking for women. Women came to us. In fact, it became a bit of a nuisance sometimes when you're getting sort of 6 or 7 calls in the one day after another, looking for help, because this was done in our spare time. It wasn't something that we were paid for. It was a voluntary service that we were providing because women had the need and were requesting it. So that's how it came about.
So how effective is it as a drug at interrupting pregnancy? It's not 100% or anything.
It's not 100%, no, and it depends. There's lots of factors. The two ones that we know about are the stage of pregnancy. So if a woman is if she's only 4, 5, 6 weeks pregnant, then the chances of success are much less than if she's 9, 10, 11, 12 weeks. I received calls personally from 92 women. Now, I think 1 or 2 of them may have been bogus calls that were trying to catch us out. But of 90 or so women, and then about a third of them decided not to go ahead with the treatment. So that, again, flies in the face of people say that we were pushing our pro-life views or we were judgmental. We had a discussion, and some of the women following the discussion and being told the benefits, the risks, which are very, very low, mind you, and we'll come back to that, But about a third of them decided not to go ahead with the treatment. Some of them started treatment, but then within a matter of days decided they weren't going to continue, even though the initial treatment appeared to be successful. And it was, in most cases, it was due to coercion from boyfriends or partners, unfortunately. But that happens. So of the women that we have helped, we have a success rate of just over 50%. And now that's a little bit less than the American studies. The American studies, which are observational studies, suggest that success rate using oral progesterone, which is what I was using, could be up to 68% successful. Now that depends on, first of all, the service being well known, that it's that the woman changes her mind very quickly and seeks help very quickly. So the second factor is the duration or the time delay between taking the mifepristone and then seeking help and getting active progesterone treatment. If there's a long delay, then the chance of success are obviously going to be less than if you receive the progesterone treatment very, very quickly. So our overall success rate was just over 50%, whereas in the US studies it was up to 68%.
And what are the benefits to the woman in this case?
With progesterone?
Yeah.
Yeah, you would like to say none. You can never say none, but progesterone is widely used in pregnancy. It's been around for about 50 years, so several decades of progesterone use in pregnancy. There are women who have recurrent miscarriages, and that can be for lots of different reasons. But one of the more common and treatable causes of recurrent miscarriage is low progesterone levels, especially in the early stages of pregnancy. So progesterone has been used to try and support pregnancies, not always successfully, I have to say, but it is a recommended treatment for women who have suffered recurrent miscarriages. And it used to be they had to have at least 3 miscarriages. Now they're bringing it down to, if they've had 2 miscarriages, then they become a candidate where they might be considered for progesterone treatment with future pregnancies. It's also used very commonly at the start of IVF because it's essential for maintaining the pregnancy. So progesterone is very safe. And in the abortion pill reversal situation that we were given it was for very short-term use. So we would give it depending on the stage of pregnancy. So if a woman was maybe 6-7 weeks, we would continue it for 5 or 6 weeks up until they were well into the second trimester.
However, even though it's safe, it isn't actually licensed in the United Kingdom for the purpose of abortion reversal, and that's where the problem occurs. Is that correct?
It's part of the reason why the problem occurs. It shouldn't be a problem because, for example, misoprostol, the second abortion drug, that's not licensed for abortion. And people don't realize that. Mifepristone is purely designed for that purpose. Mm-hmm. There are many drugs in common use that are designed for a specific purpose, and then years later, or sometime later, other uses are found for them. And they become used and trialed and found out to be successful in other areas. And sometimes they eventually receive a license for that specific use. Sometimes they don't. Another commonly used one is methotrexate, which is a dangerous drug. Methotrexate is widely used in rheumatoid arthritis and other chronic inflammatory conditions. But it is also the drug recommended by the Royal College of Obstetricians for medical treatment of ectopic pregnancy. And it's not licensed for that use. And that is a potentially dangerous drug, whereas progesterone is a very safe drug. It's a natural hormone. We use natural progesterone. It's for a short-term period. And I would point out at this stage that in the US, there have been over 2,500 live births from women who had initially taken mifepristone and who changed their mind and then received rescue treatment using progesterone. So 2,500 without any adverse reactions for the mother. Now, again, there are side effects. Every drug is a potential poison. And just as I mentioned, mifepristone, misoprostol have painful and sometimes horrendous side effects. Progesterone has side effects. And any of the women that I treated, I had to warn them that, you will feel quite sick. The reason that women get sick, mothers get sick in early pregnancy is largely due to progesterone. So it will make you sick. It might make you very tired. It sometimes causes dizziness. A small number of women have said they feel spaced out, especially the first 3 days, because in the first 3 days we were given quite high doses to get them started on the treatment, and then we could relax a little bit and half the dose. And usually there was very little problem once they got over the first 3 days. So some had continuing unwanted nausea or tiredness being the 2 common side effects. So every medication has a potential adverse effect or unwanted effect.
So how is it then that you end up, shall we say, before the the courts, not indirectly, shall we say, how you end up in trouble. You get reported, and you are, as you say now, you're not in a position to make, you can't advocate or recommend the use of progesterone, and you have other terms that you have to obey in order to be able to continue to be licensed to practice medicine. So how did that happen? What happened?
We were reported by, the complaints were made by some of the abortion providers, particularly in my case, Mary Stopes International. And this is well documented in the press. And also the Royal College of Obstetricians, who didn't like what we were doing. No, it's very important to realize that not a single patient that we had any interaction with complained. In fact, all of the patients, even those where the treatment wasn't successful, all of them have been very, very grateful that somebody listened to their concerns, listened to their request, helped them to try to save their babies. At this stage, again, personally, of the women I've helped, 12 babies. In fact, I just heard 12 babies have been born. There's another 10 due in the coming weeks. My colleague who was doing it in another part of the country, she has a smaller number to treat than I had, but she's had 10 or 11 babies as well. All of whom are healthy, by the way. And that's the studies from the US show that the 2,500 plus, there isn't any increased risk of problems or of congenital problems for the babies who are saved in this way. So we were reported to the General Medical Council. I can't go into all, because it's a sort of a matter before the courts, if you like. I can't go into all the details, but they didn't like what we were doing. The number of issues were brought up, such as you mentioned, and which is already in the public domain, that we were using an unlicensed medication, that we were doing it remotely. That's a little bit hypocritical, I think, because as I mentioned at the start, the majority of abortions are medical, and the majority of them nowadays, over the last 2 years, have been carried out by telemedicine, by a woman making a phone call to another part of the country. For example, one of the ladies that I helped in the south of England received help from a Mary Stopes clinic in the northwest of England, and they sent her the pills by post, which she took a few days after she received them. So unlicensed medication, remote prescription, not seeing the patients, not following the abortion guidelines as laid down by the NHS, which I'll let your listeners decide. But we've answered all of the allegations that were made against us. We've put before the General Medical Council, and if it goes to a higher court, we'll be putting the same responses that we've made. But we certainly have no concerns that any of the allegations hold any water, or that they're reliable or enforceable in any way, because we haven't broken any law.
Sure.
We haven't gone against, at least we don't believe we've gone against any of the measures of good medical practice as laid down by the General Medical Council. And we're hoping that when these are properly and fully investigated, that will have shown to be the case.
What struck me when I was reading about this case, and not just your story, but the story, a number of women who had been helped talked to the newspapers about their experience. And then there were just general articles, that one of the things that seemed to come across was, and we've heard this in other contexts, that once abortion becomes established in a medical culture, that something seems to happen. And we've seen that even in Ireland, when you're talking about in certain departments, shall we say, certain hospitals, when you're dealing with difficult pregnancies or fetal life-threatening or life-limiting conditions, that it becomes the default thing. And the catchphrase has always been that abortion should be safe, legal, and rare. But I have a strong impression from reading around this story that there are many, many women who find themselves in crisis pregnancies. And I'm not talking about the NHS here, because most abortions in the United Kingdom happen outside of that system, but large-scale abortion providers. And the default position is the assumption, well, why wouldn't you have an abortion? Isn't it the simplest, least complicated, most cost-efficient thing to do? And women who maybe are looking for support to take another choice are not being given that support. That something seems to happen. a momentum develops in a direction. And I think that I'm talking about this because I'm very aware in Ireland, we're at the beginning of that process now. And I think we should be very careful about that the idea that we should support women shouldn't just become just like a tag, but something real. Because in this case, it seems to me there are a lot of women reporting also the fact that they were making a choice. It's all about choice, but this particular choice was not being supported, rather ironically.
True, yeah. So that's one of the arguments that we've been having, that it was interesting that in the allegations made against us, we were described as, we were members of an anti-choice organization, but we were the ones offering the women the choice. And in none of the situations, and several of the women have come forward to support me in this and have made sort of official legal statements. And none of them knew anything about my religion. They were asked specifically, and do you know what religion Dr. Kearney has? And none of them knew. Two women later did ask me, but can I ask you, are you, one woman asked me, are you a Catholic? Because her dad was a Catholic. And another girl asked me, how did I get involved in doing this rescue treatment? And I told her about the Catholic Medical Association. That's the only two times religion ever came up in the conversation. We never put pressure on the women to go ahead with treatment. In fact, you could argue that the women never, I never said anything that I was a member of a pro-life organization or a Catholic organization. And for all they were concerned, I was a doctor who was offering them an option when they had chosen to go ahead with this option. So for all they knew, I could have been the most avid pro-choice doctor in the country, and because they never knew otherwise, because I never told them. And that nobody ever asked me. They just asked me, can you help me to undo what I've done? And sometimes it wasn't possible. Sometimes we had to be honest with it, and it was too late. And other times it was possible that we could at least give it a try and then see what happened. Yeah, so it comes across very clearly to us that many of the women, and they told us that it was, and they regretted that they were the ones who had to experience it, that it was too easy. They made a phone call, they were asked a few very simple questions, and we know this from, again, sort of mystery client investigations that this takes place. Very little was asked about their circumstances. Is anybody putting you under pressure to go ahead with this motion? I'm not saying that doesn't happen, because obviously we have very limited experience. We only know about the ones who came forward to us, but we know that it certainly does happen in some places. There may be some very good and maybe very caring providers, and even though we would feel they're misguided in this context, but we know that it certainly happens where women are not asked anything about, are you sure that you've looked at the other options, and is there anybody we can talk to? Do you want to have a period to think about this? Do you want to have some counselling? Do you want to be referred? They certainly aren't ever referred to any of the organisations like Good Counsel or Life or 40 Days for Life or Rachel's Vineyard, or some of the organisations that would actually offer them real choice rather than abortion. And they're never told, oh, by the way, if you change your mind, there are doctors out there who might be able to give you reversal treatment. That certainly isn't on the cards. In fact, they were told, because many of the girls that we helped they informed us that before they found us, before they went to Google, they first of all went back to the abortion providers, told them that they didn't want to go ahead, and they were told, sorry, there's nothing you can do. You can either just take the second pill or just wait and see what happens. A lot of them went to their own GPs and were told more or less the same thing, or they were told to go back to the abortion providers. Some of them went to A&E departments and were told, sorry, there's nothing can be done. So it was only when they found us that somebody at least gave them another choice.
I mean, one of the things that's, and I don't want to sound disingenuous here, but slightly puzzled me was the fact that it was the abortion suppliers, the abortion providers that were reporting you, in the sense, but why do they care? In a sense, what business is it of theirs? If these women have made this decision, this hormone has been used for a very, very long time, maybe not specifically for this purpose, but it has a strong, fairly well-proven safety track record. They can't realistically claim that this is because this represents some kind of a physical threat or danger to them. It's almost as if they're offended by the fact of the nature of the choice that these women are making.
Yeah, I think so. I think that's the key thing. I think it's a threat. It's a threat to the whole ideology. I think that the the most telling thing, first of all, before actually, I should have mentioned at the start, before we went ahead with it, we actually wrote to the Royal College of Physicians, or sorry, the Royal College of Obstetricians, Gynecologists. We wrote to NHS England, we wrote to the Royal College of GPs, telling them about the evidence that was available for this, and that we in the CMA would like to recommend it and go ahead with it. And we just wanted a little bit of backing, a little bit of support. And they came up with these excuses, oh, we can't promote something that's unlicensed, and yet they were given the methotrexate, as I mentioned, and misoprostol. There isn't a strong enough evidence base for it, and yet there is evidence. It's true that we don't have a randomized controlled trial, and that's pretty obvious for ethical reasons. You can't say, oh, we'll send this group for an abortion, or we'll send this group for it. So there are strong ethical arguments as to why that can't properly take place.
Sure.
The most telling, I think, comment came from a guy in the US, a doctor called Dr. Daniel Grossman. He's a well-known abortionist and a well-known opponent of abortion reversal in the US, probably the most outspoken of all. And there's an interview with him that I saw on a YouTube in 2018. He was interviewed by, it's a thing called Vice News. You've probably come across it. And he was asked specifically, and I'll just read this out. Is this just about the medicine for use? The medicine meaning the efficacy, the safety, and so on, or is it about the politics around abortion? He was asked that question by a journalist from Huffington Post, which it's not a pro-life organization, I don't think. He said, no, of course, this is about the politics, and it's about rhetoric. You know, it's about all of this talk about reversal makes people think that women really are very conflicted in their decision. So I think it's a challenge. I think it's an affront to them that women change their minds. Because they like to think a woman has decided, she's decided she wants an abortion, she's made up her mind, she'll go ahead and do it. And we know that that's not always true. So I think this is a challenge to that concept that women do change their mind, because if you accept that women change their mind, the next question is, well, why do they change their mind? And the answer, I think, is because they're not getting proper counseling, they're not getting proper support. And if that's then addressed, then it changes the whole scenario, change the rhetoric, and use Daniel Grossman's phrase. So that's my, otherwise I can find no other reason why they would want to oppose what we were doing.
Maybe crudely speaking, it changes the business model. Yeah,
possibly.
I'd like to thank you very much. I'm aware of the time and I don't want to keep you too much. Maybe we'll come back to you, not just on this issue, but from the point of view of talking about the work of the Catholic Medical Association in England and this and on other subjects. But for today, I would like to thank very much Dr. Dermot Kearney for joining us. I'd like to thank you for joining us today. And again, as I say, hit that subscribe button. And again, if you can support us in these issues, any donations you make will be greatly appreciated. So for the time being, and stay safe, keep washing your hands and mind yourselves all. Thank you again, and thank you, Dr. Kearney.
Thank you, Michael. It's been great.